Now we'll just, thank you. So this lecture is about stroke and the mnemonic be fast, and obviously you can see it posted next to my head here, but we'll also talk about that as we go forward when we talk about stroke. I was asked to do this talk because everybody needs, I guess, some stroke education, certainly, but it's sometimes mandatory for people who have stroke centers, et cetera. And I understand we have people joining us from all over the state and maybe even out of state, Connecticut and Massachusetts. I think there are some people joining us as well. So thank you again for attending. And we will go ahead and start talking. So this, this presentation was actually developed by Genentech, and it's especially for EMS. You can see EMS for stroke, the first line of defense. Genentech, just so you know, is the group that makes the Activase or the TPA, or the clot busting medication. So they're the company that manufactures that. So this is their product, certainly to support their pharmaceutical product as well. So again, they developed this especially for EMS. So I've borrowed a lot of their slides, and it certainly makes sense when we're working with their product. So the introduction is again just to enhance what we do and make sure that we are all doing the right thing. And the way that they broke this down is it's organized into 3 different chapters, and in each chapter, the way that they did it, it ended with a case study. It was the same case study for each chapter. I chose not to do the case study because we're just going to talk about, the management of stroke and how we do that. So, but here are the goals for this presentation. So you certainly will be able to describe the importance of recognizing stroke urgently and acting quickly. You'll be able to detail the role of EMS in pre-hospital stroke management, which is obviously what we want to do. Describe the importance of timely arrival, distinguish between the types of stroke centers, describe the impact of stroke disability on patients and their families, and then utilize the materials to spread stroke awareness. So what they want to do too is not only teach us, in EMS about what to do with stroke, but certainly how you can roll this out to your communities and how you can teach your communities how to recognize stroke and what to do for stroke. If at any point anybody has any questions, you can certainly unmute yourself or just jump on the chat here. Hopefully I'll see that light up, but feel free to unmute yourself and just jump in at any time, okay? All right, so again, table of contents, there's going to be 3 chapters. Essentially, first is, we're going to identify stroke, what is stroke. Chapter 2, we'll talk about the role of EMS, and then chapter 3, talk about the consequences of stroke, like the disability. And then I have, some other roles of EMS and how we can best take care of stroke. So a little bit of history. If you guys have joined me before, I like medical history. This is King George, who suffered an episode of what they called apoplexy. So what we know about stroke started way back 400 BC. Hippocrates first described this phenomenon of being suddenly struck down with paralysis, and he coined the term apoplexy, which again, that was King George having an episode of apoplexy. And it literally means just struck down with violence as if by the hand of God. So back 1599, sometime later, is when the term stroke was actually first used as a fairly literal translation of that, being struck down. So this is where the word stroke came from for what happens to these people. You can see by 1658, they knew that stroke arises from a disruption of blood flow to the brain. And by 1847, Virchow established that atherosclerosis and clotting was a definitive cause of ischemic stroke. So I think that's pretty neat that, that's almost 200 years ago now that they already knew that there was atherosclerosis and clotting was causing stroke. So this is what kind of broke this all open, was back in, and I can't believe it's this long ago already, 1995 is in the New England Journal of Medicine, they showed that tissue plasminogen activator, or TPA, could be used for a treatment for acute ischemic stroke. And this is, the big study that they did with with TPA and the National Institute of Neurologic Disorders, and came out with these findings. By June of 1996, TPA was approved by the FDA for the acute treatment of stroke. So again, this is what started it all. 4 years later, June 2000, published in JAMA, was the recommendations for the establishment of primary stroke centers. So in looking at some of the guidelines for the stroke centers, certainly one of the key points to having stroke centers and having this whole system was EMS, and certainly that's why we're here tonight. So the first chapter of the of this slide series is, what is stroke? So the learning objectives is to understand the incidence and the impact of stroke, describe the two types of stroke, and then identify different stroke symptoms. So this is just some statistics about stroke. It's a major cause of morbidity and mortality in the United States. You can see that it strikes about 795,000 people a year, which is certainly a lot. Leads to over 142,000 deaths a year. It's a leading cause of serious long-term disability, certainly. The stroke occurs on average of every 40 seconds. Again, that's kind of hard to believe, but you look at how many people are affected. So about 1 every 40 seconds, somebody's going to have a stroke. And it results in death on the average every 4 minutes. And the cost is projected to more than double between 2015 and 2035. It's the 5th leading cause of death. This is kind of, I think we may be making progress, because I looked at my previous stroke talk that I had done, I don't know, a year or two ago, and at that time it was the 4th leading cause of death. So maybe we're making some progress here with stroke. But anyway, 5th leading cause of death. You can see obviously it's a major cause of death for people in the United States. This is the risk of stroke varying with race and ethnicity. You can see that it's more than double the incidence of stroke in Blacks. And these folks are more likely to die from stroke than any other racial or ethnic group. And Hispanics have a high incidence of first stroke compared with whites as well. So again, this is when you're talking to your community, when you're, sharing this with your community. These are just some statistics that, really kind of stick out. And then it affects women more than men. You can see the numbers there, 58% to 42%, women versus men will have a stroke. And again, this helps when you're talking with your community about it. And here's the scary stuff, right? The incidence of stroke in younger people is increasing. 2009, which is a while ago now, over 1/3 of people hospitalized for stroke were under the age of 65. You can see there about, 34%, or about 1/3 of the people were under 65 years old, and that's pretty scary. And then you can see the graph on the right there that again, the number of people from 18 to 64 years old who have had a stroke is predicted to increase over time. So again, this is something that's certainly not going away and may even be getting worse. So something that we have to certainly get a handle on. So the two different types of stroke, first is ischemic stroke, and that's when you have a plaque or a clot that blocks blood flow and starves the cells of oxygen. And that is certainly most types of stroke. About 87% of strokes are ischemic. The other type of stroke is what we call hemorrhagic, or just bleeding, right? So the blood vessel leaks or breaks, and then you have bleeding into the brain, and that is a hemorrhagic stroke. Much less common, about 13% for hemorrhagic stroke. So again, this is the same thing. Ischemic strokes, the underlying cause is atherosclerosis. Like I said, we've known that for almost 200 years now. Two different types of ischemic strokes. One is the thrombotic stroke, and that is when there's a thrombus in the vessel, a big clot in the vessel. And this is most of ischemic strokes, about 60%. And this is a big stationary clot that is, forms and just gets bigger and bigger and bigger. And what happens is the symptoms develop gradually and progress, until there's a total blockage of the vessel, and that's when you get a problem. these are the types of strokes that, people may go to sleep okay, and then they wake up in the morning and, they have symptoms of a stroke. And it's just, again, it's one of these things that kind of gradually develops over time from a stationary clot. The other type of ischemic stroke is an embolic stroke, and that's when the clot travels from somewhere else. So certainly you can have an atheroembolic event from one of the large vessels, or a cardioembolic event from the heart itself. And when you talk about cardioembolic strokes, one of the leading things we think of is atrial fibrillation, because the most common cause of cardiogenic embolism is atrial fibrillation. And you can see that the risk of stroke is increased about 17-fold in patients with AFib and valvular rheumatic heart disease. So this is a major cause, major problem here. But embolic strokes can also occur in association with an acute MI, particularly with involvement of the anterior wall. What happens is that you have a sort of a non-moving wall, and clots form there. And again, you can flip off a clot from a dead heart wall or a valve, or again, if you have AFib and you sort of flick a clot, and that causes an embolic stroke. And when these happen, you have a sudden onset of symptoms, right? You're fine 1 minute and not the next, as that clot travels from wherever it came from and then lodges in the brain. So this is an embolic stroke. Hemorrhagic stroke, as I said, a vessel opens or starts bleeding, you get bleeding into the brain tissue or the areas surrounding the brain. The brain is damaged from the direct trauma to the brain cells, or from the increased intracranial pressure, or the spasm of local blood vessels, or the swelling that occurs. So there's multiple ways that it causes, it's not just the blood itself, but the other, increase in pressure, et cetera, that can cause damage to the brain. Two major types of bleeding into the brain or hemorrhagic strokes. One is the intracerebral hemorrhage, and the other is a subarachnoid hemorrhage. And if you guys were at rounds last month when we talked about trauma, this is the same two things. So intracranial hemorrhage, this is an intracerebral hemorrhage, bleeding directly into the brain tissue itself. So you can see on this CAT scan, the white material here is blood. So this is bleeding into the brain tissue itself. This is an intracerebral hemorrhage. Usually it's a damaged vessel, most commonly because of hypertension. So the high blood pressure is going into these small vessels, the vessel ruptures and bleeds into the brain tissue. It's much more common than a subarachnoid hemorrhage when you're talking about hemorrhagic strokes. But this is a subarachnoid. This is bleeding into the subarachnoid space. This is where the vessels are running in that subarachnoid space. So if you have an aneurysm or an AV malformation that ruptures or opens, this is where you get the bleeding into the subarachnoid space. What it looks like on scan is you see this blood, the white blood is kind of everywhere, diffused through the subarachnoid space. And again, this is less common than intracerebral hemorrhage, but certainly just as devastating. Both intracerebral hemorrhage and subarachnoid hemorrhage carry a higher acute mortality than ischemic stroke. You can see that, there's not a lot to do to get that blood out of there, unfortunately. So again, kinds of stroke, ischemic stroke, certainly much more prevalent. So, 87 to 13%, certainly we're more likely to see an ischemic stroke than a hemorrhagic stroke. And you can see the breakdown there of hemorrhagic strokes. Again, intracerebral, much more common than subarachnoid. I do want to take a minute to talk about TIAs, or transient ischemic attacks. It's estimated here, these are numbers from, I think, 2011, between 200,000 and 500,000 occur in the United States per year. That number we might not even be accurate at, because some people probably have TIAs and don't seek treatment, right? So we don't even know what that number could really be. Certainly prevalence increases significantly with age. This is one of the things that's going to happen as people get older. And of course, TIAs are essentially mini strokes, right? So the symptoms of neurologic dysfunction are the same as for stroke, but they are temporary and resolve without detectable tissue damage. So by definition, they are transient. The problem is that anywhere from 9% to 20% will have a stroke within 90 days. So that's why this is very important to take seriously, certainly, when you have a TIA, is because people may go on to have a stroke. So immediate medical attention is required. Again, TIA, it's a temporary interruption of blood flow to some area of the brain, and then you have the same signs and symptoms that you would of a stroke, but they resolve, right? Now, by definition, it says that they will resolve within 24 hours. Usually, though, as we know, and as you've probably seen, symptoms really last only for a few minutes or an hour, right? Somebody's talking on the phone and they can't speak for a little while, and then by the time you get there, they're already better. So again, it's something that resolves, and by definition, certainly within 24 hours. The problem is, and as you've probably dealt with, when you get called to these, homes or whatever, that, because things have gotten better, patients may refuse to go to the hospital or refuse to be seen in the hospital. And certainly we see it as well in the ER when people come in and their symptoms have completely resolved and they think, that they're fine and everything is fine. Again, the problem is that up to 30% of patients will have a major stroke in the near future. So again, this is a warning sign for a more major stroke. There are some scores you can use, or helpful little sort of tips to use, to predict, well, who's going to have a stroke, who's at risk, what's the risk to these people, and how can I sort of share that with them. This is called the ABCD2 score, and you can see on the right, it's a mnemonic for age, blood pressure, clinical features, duration, diabetes, and they get points for these things. You can see on the table there, and then you put that score against the risk over there, and it kind of tells you their risk in certain amount of days, their risk for having a stroke. This has been shown to be not at all clinically accurate. It was developed not for medical folks, but more as a screening tool. And I just wanted to kind of bring it to your attention. It's out there. It's not been validated. There's been studies that show that it really is not so good. So, but what is good, what has recently been validated, is the Canadian score. Of course, the Canadians are good at this kind of stuff. They have the Ottawa ankle rules, they have the Ottawa knee rules, they have the Canadian C-spine rules. Well, now there's the Canadian TIA score, and you can see it's this same basic kind of thing. You give patients points for, whether it was their first time, how long the symptoms lasted, if they're, what their platelet count is, things like that. So again, you tally a system of points there, and then you put it on the risk table, and you can see that you can identify what risk people are at for stroke just by tallying the score. And again, this is helpful stuff to tell people, to say, hey, look, you have a 5% chance that you're going to have a stroke, within 7 days, or then it may make people either want to take the ride to the hospital or certainly be admitted to the hospital when we can tell them that they are at risk. So again, these scores are out there. This one has been validated. This is a good score. So you can take a look at this stuff. It's in probably all your MD Calc kind of apps and stuff like that. So identifying stroke certainly presents in many ways with varying intensity. These are some common signs and symptoms, and we'll talk about this one other time. But again, if you have an embolic stroke, these things kind of appear suddenly, and I'm sure I don't have to tell you, but numbness or weakness of the face, arm, or leg, confusion, trouble speaking or understanding, trouble seeing with one or both eyes, trouble walking, dizziness, vertigo, loss of balance, coordination, sudden severe headache with no known cause. That typically that's like a subarachnoid hemorrhage. But there's other stuff. There's respiratory abnormalities, difficulty swallowing, nausea, vomiting. And again, the symptoms of stroke can be really, sometimes not clear cut. So, you kind of have to have suspicion for stroke. And of course, the presentation is going to vary based on which vessel of the brain is occluded and what area of the brain becomes ischemic, right? I mean, that only makes sense. And we talked about this last month, but obviously, different parts of the brain do different things. And this is the Genentech slide. You can see that the frontal lobe is, sort of your personality, if you will, your mood, etc. Occipital lobe is where your vision cortex is. The cerebellum is responsible for coordination and movement. So, and if any of these areas are affected, then obviously that's the signs and symptoms that you're going to see clinically with these people. So again, I showed this last month. This is called a homunculus, and this is sort of a map of the brain, if you will. This is like the brain on edge, cut on edge, and then you see this sort of roadmap to where things are. And again, depending on where the stroke affects is obviously going to determine the signs and symptoms that you see in the patient. In particular, though, there are a couple of unique kind of stroke findings. A parietal lobe stroke, for example, so a stroke in the parietal lobe of the brain can produce extinction of the opposite side of the body. So the patients may, if they have a stroke affecting the right side, they may completely neglect the left side of their body, to the point that, when they comb their hair, they only comb the right side of their head. And the patients may even deny having a stroke because they don't realize that they are denying that side of their body. So, rather, it's kind of rare, but it is one of these stroke findings that's, pretty impressive when you do see it. There's also a group of lacunar strokes, and a lacunar is just sort of a punched out lesion in the brain tissue, usually from like a hypertensive bleed or a small area where a vessel has a problem. And there are specific lacunar strokes that you may see, and certainly the most common is the dysarthria, clumsy hand stroke. And these are people who come in and they say, they feel like they're mumbling, they feel like their voice is mumbling, or somebody may say, we can't understand him, his words are mumbled, and then they'll say, I dropped my coffee cup this morning, or something like that. So it's so again, that's the dysarthria, clumsy hand, but there are other lacunar stroke symptoms as well. The pathophysiology of stroke. Well, brain cells need oxygen, glucose, just like every other cell in the body, but certainly the brain needs energy, needs oxygen to survive. Any decreased cerebral blood flow causes brain cells to become electrically silent. So they're going to start to die off, right? If they don't get blood flow, the cells eventually are going to start to die off. If the flow, finally continues to drop, then the cells begin to die. And that's obviously where the issue is. So the area that actually dies is, you can see there on the diagram, is the area of infarct, is that black area, but the area of brain surrounding the primary stroke site that continues to receive cerebral blood flow from collateral circulation is called the ischemic penumbra. So this area around the dying tissue is called the penumbra, and that's the area that's sort of at risk, right? So the cells of the penumbra are metabolically active and potentially salvageable with timely intervention. And that's why, the timing of our care, the timing of intervention for stroke is so critical, is because we're going to, save the cells in what we call the penumbra. So, otherwise the infarction spreads over time into the penumbra, and then it makes it all irreversible brain damage. So again, when we can intervene, we can certainly increase functional improvement in that area. So again, this is their slide for the goal is to save the penumbra, right? The penumbra is the salvageable part of the brain that surrounds the infarct area. And again, this is our target, is to save as much brain as possible. So again, signs and symptoms of stroke. And again, I'm sure I don't have to tell you guys this, but facial droop, slurred speech, numbness, headache, weakness, paralysis, confusion, altered mental status, gait disturbance, dizziness, loss of balance, loss of vision, inability to understand, or incontinence. And these are, signs and symptoms of stroke. One of the things that happens quite frequently is you get patients that come into the ER, with some vague dizziness. They get admitted to the hospital for dizziness or dehydration or something, and then come to find out, later they have an MRI and it shows that they had a stroke. So, ultimately the discharge diagnosis is stroke. So what we want to, try to do is, concentrate on these signs and symptoms when they first present, and then always have kind of stroke as a differential diagnosis. There are some stroke mimics, right? Some things that make you think that a patient is having a stroke when clearly they're not. The biggest is hypoglycemia. I don't know, I think we've all been embarrassed by patients who are, completely altered and we think they're having a stroke or something else is going on, and we get a finger stick and their sugar is 20, right? So certainly, getting a finger stick, and we'll talk about this later on, but certainly, patients who are hypoglycemic, and if you've seen people who are really hypoglycemic, they look like they're having a stroke. They're kind of certainly out of it. Seizures, again, seizures can be a stroke mimic. There is a condition called Todd's paralysis that occurs after seizures. What happens is that, after a seizure, you may get paralysis of, say, one arm or one leg or something like that. Again, it's called Todd's paralysis. It occurs after a seizure, and certainly that can mimic a stroke. You have somebody who's somewhat altered, and then, paralysis of one side of their body certainly could, make you think that they're having a stroke. Complicated migraine, people who have, migraine history, if they have these complicated migraines, they can sometimes end up with numbness or paresthesias on one side of the body, and certainly that can mimic certainly the signs and symptoms of a stroke. Hypertensive encephalopathy, if people are, so hypertensive that the, blood pressure is going to their brain, can certainly alter them and make it look like they're having a stroke. And then finally, Bell's palsy, which is a paralysis of the facial nerve, which causes, one side of the face to droop. So facial drooping, inability to close the eye, maybe some garbled speech because the face is drooping. And again, this is a localized problem with the facial nerve and not a stroke, but certainly can sometimes mimic a stroke. So again, there are things that, may present like a stroke, and we, it's our job to kind of, make sure that it's not. So what are the risk factors for stroke? Well, certainly hypertension, especially in the case of, hemorrhagic strokes, where, the high blood pressures in these small vessels will, cause the vessels to break or leak or certainly bleed. Diabetes is a risk factor for stroke. Diabetes is a disease of the blood vessels. I know it's the pancreas and sugar, et cetera, but it really affects the blood vessels. And that's why diabetics are, at so much risk for heart disease and stroke, and, vision loss is because of the, how it affects the blood vessels in the eye. So again, it's a disease of the blood vessels, and certainly diabetes is a risk factor then for stroke. Coronary artery disease, if they have atherosclerosis in the coronaries, they certainly probably have it everywhere. And, they may have limitations in the blood flow to the brain. Cardiac dysrhythmia, I talked about AFib, certainly a 17-fold increase in stroke when you have AFib or valve dysfunction. So again, cardiac valve dysfunction. Hyperlipidemia, or high cholesterol, high triglycerides, certainly is a setup for these plaques and clots to form. And then coagulopathy, if you have some sort of inherited coagulopathy where your blood, coagulates quickly, or you form clots, certainly you're at a risk factor. This could be a risk factor for stroke, as these clots can certainly end up in the brain. So again, these are some of the risk factors for stroke. And when you see, patients with these histories, certainly that heightens your awareness to the possibility. So a summary for this first part is that, stroke is the 5th leading cause of death in the U.S., certainly is something that is not going away. 87% of strokes are ischemic. Certainly most of them are ischemic, but 13% are about 13% are hemorrhagic or bleeding. Stroke presents in many ways with variable intensities. And again, that's important to keep in your differential when, when you're dealing with people with these symptoms. It's a major cause of morbidity and mortality. And the penumbra is the tissue surrounding the infarction. And that's the area of the brain that is potentially salvageable, and certainly why we want to act quickly with the treatment of stroke. Okay, so let's go on to the role of EMS. What is your role in this whole thing, or our role in this whole thing, I should say. And the learning objectives for this chapter, we're going to understand the guidelines for the EMS management of stroke, and I'm going to talk about those in a little bit of detail after this chapter, kind of, and then how can we best carry out, care for people with stroke, and talk about the different levels of hospitals that can treat a stroke and the difference in what you may find in different hospitals. So the role of EMS, certainly the most important thing when you're bringing somebody in with symptoms of a stroke is pre-hospital notification, right? So you definitely want to let the receiving hospital know that you have a suspected stroke patient so that they can prepare for your arrival and prepare, the team and resources they need to take care of the patient the best. When you're en route, you certainly should let the hospital know the time of symptom onset. Certainly, what kind of time frame are we dealing with? You know that we have a specific time window in which to give TPA and do things. So certainly that becomes important. The medical history, just talk about that, and we'll talk more about that in a little bit. And the medications that patients are taking, again, is going to become important. But again, the pre-notification thing is certainly important to have people on board when you hit the door. So again, this is some of the management stuff, and I'm going to talk about this again, but certainly you manage used to be the ABCs, now it's CABs, I guess, give oxygen, do a pre-hospital stroke assessment, and we'll certainly talk about that in a minute. Again, record the exact time the patient was last seen normal, because we're on a time clock here. We're on some time limitations. We have to know when things certainly started. If possible, bring somebody along who, especially if the patient can't talk or can't communicate, certainly bring somebody along who was there and witnessed it or can, communicate for the patient. Medical history, again, what's important, certainly current medications, especially if they're on any anticoagulants, aspirin, Coumadin, Xarelto, any of these, novel agents. This is going to be especially important and certainly, puts people at risk for, hemorrhagic strokes as well. And then, again, we'll talk about, what's important with medical history to know when they come in. So again, we have these pre-hospital stroke assessment tools that enable us to identify and prioritize stroke patients, right? So we know from studies that formal stroke assessment tools can increase paramedic sensitivity to stroke identification to greater than 90%. So again, we have these tools, we have these scores, that we use, and certainly the ones that are most frequently used are either the Cincinnati Pre-Hospital Stroke Scale or the Los Angeles Pre-Hospital Stroke Screen, or the Los Angeles Motor Score, which you're familiar with in Rhode Island from the protocols. And we'll talk about these scores and tools. So again, these are, you see some of the pre-hospital stroke scales on the left there and their sensitivity and specificity. You can see that the Los Angeles Motor Scale, again, what is used or referenced in the Rhode Island protocols, 81% sensitive and 89% specific. So that's pretty good for both. Cincinnati, 83% sensitive, not so good with specificity. So the Cincinnati score is not as good. The LAM score certainly is the best, and that's why it's referenced in our protocols. There are other scores there that I'm less familiar with, but certainly the Cincinnati and the Los Angeles ones are the most commonly used. What are the different types of stroke centers? Again, this was identified, way back when they started this whole pushback, 20 some years ago, that there are different levels of stroke center. Certainly the top is the Certified Comprehensive Stroke Center, and that's a multifaceted 24/7 stroke care, and we'll talk about each of these. And then under that is Certified Primary Stroke Centers, and then acute stroke ready hospitals, and then thrombectomy capable stroke centers. And again, these are the 4 types of stroke centers that are identified for the treatment of stroke. If you look at the Rhode Island Department of Health webpage, and certainly people in Rhode Island and nearby in Connecticut, et cetera, know that we do have one comprehensive stroke center in Rhode Island, and that's at Rhode Island Hospital. The good thing is that any hospital in Rhode Island is a stroke-ready hospital. Certainly Westerly is classified as acute stroke-ready, but all the other hospitals are primary stroke centers. So, the bottom line is that you could go to any hospital in Rhode Island and you will get, thrombolytic care for acute stroke. So you can see there some of our neighbors in Connecticut, Lawrence and Memorial, and as well as Dake Kimball are also primary stroke centers and, nearby on the border. So again, we have pretty good access to certainly stroke care in this state. And again, this kind of breaks down what is the difference between these centers, the comprehensive being, the sort of the top with, the 24/7 stroke care, dedicated stroke care, neuro intensive care beds, et cetera, et cetera. Again, all the other hospitals are able to give thrombolytics. So any of the, other than Westerly, which is stroke ready, all the others are primary stroke centers. So they can give IV thrombolytics and certainly can manage cases of stroke in the hospital. The difference with the acute stroke ready hospital is that there are no designated beds for acute care of stroke patients. So that's the only difference. Again, you can give IV thrombolytics, and then they anticipate that they'll transfer the folks for continued care. So again, any hospital you go to in Rhode Island is going to be, capable of at least giving thrombolytics, and then some a little more. So when do you bypass one for the other? Again, as I said, any hospital in Rhode Island is ready to give thrombolytics. So any positive stroke screen or a strong suspicion of stroke when you're doing a history and physical on your patient, you can go to any hospital in Rhode Island and you will get, the care, or the patient will get the care that they need there. If you're talking about a large vessel occlusion, is either suspected or identified, and it's either suspected because of a Lamb score greater than 4, or certainly identified at one of the other hospitals by CT scan, then these patients should be then sent on to a comprehensive stroke center. And again, in Rhode Island, that's Rhode Island Hospital. So that is in the protocol, and we'll talk about that in a few minutes. What are you going to do en route? How can you care for these patients en route? And I'm going to talk more about this, but certainly oxygen, and again, maintain oxygen saturation greater than 94%. We talked about the importance of oxygen last month. We talked about trauma, so certainly greater than 90. You want to be greater than 90. Blood pressure, the treatment of blood pressure is a little controversial, and I'm going to talk more about that in detail, but certainly we're not going to worry too much about it, but again, we'll talk about that. Glucose level, though, is very important. Like I said, hypoglycemia certainly is a mimic for stroke. You want to make sure that, the patient is not obtunded and or, not moving because their sugar is too low. So certainly management of blood glucose is good. Hypoglycemia can be corrected. If they are hypoglycemic, obviously you're going to do what you do normally. You're going to give, either IV dextrose and or PO dextrose if they're awake, but only if they're hypoglycemic, not in routine care. And of course, IV monitor, all that stuff. And again, I'm going to talk about this a little bit more in detail. Feedback. Results from a survey of regional EMS providers prompted the creation of a 24-hour progress report from stroke team members to EMS in that region, leading to improved transport rates and increased EMS provider satisfaction. In other words, if we let you know what happens to these stroke patients, there's a better chance that the transports will continue, and you're going to be doing the right thing for stroke patients. So what we've developed is sort of I guess like a stroke report card, if you will, right? It's how well did you follow the protocol? How well did you kind of check off the boxes before you got there? And it's a great way to keep up on what happens to these patients once they get to the hospital and beyond. So again, it's great to have certainly have feedback when we're talking about these patients. All right, so the summary for this part. again, the performance of stroke assessment measures and rapid transport to the closest appropriate facility capable of treating stroke. And I talked about that, how we use either the Cincinnati score or the Lamb score, certainly by protocol, and where we're going in management of the ABCs, getting a history. And again, if you need to bring along a witness, that's helpful. IV monitor, going to the nearest stroke center. And again, in Rhode Island, that you can go to any hospital and you'll be okay there with stroke care. And then of course, pre-hospital notification is of utmost importance so that we can prepare for when you're coming in. What can improve patient outcomes? Well, certainly when you pre-notify us, and then, again, things are in place when you get there, and then, our feedback to you as to how things are going. So again, these are things that improve outcome. Excuse me. So this is the final chapter. It's about the consequences of stroke and the disability that happens with stroke. Disability due to stroke deficit can have lasting effects on patients and their caregivers. Certainly that should be obvious. And then we can play a significant role in educating the public or the people about stroke recognition and the need for prompt treatment. So again, this is developed so that you can kind of roll it out to your community as well, and have people recognize the symptoms of stroke and to get to treatment a lot quicker. Excuse me, sorry. So stroke is one of the leading causes of long-term disability. That's quite obvious, right? And disability defined as if you have to use an assistive device such as a cane or a walker, you can't perform your activities of daily living, or you need help doing that, or you have other impairments, and it limits your ability to get around the house or get around work. And certainly, stroke is devastating for people, because of the disability. Again, there's the National Stroke Association estimates that there are about 7 million stroke survivors over the age of 20. So again, these are patients that need, ongoing support. Some patients have even said that they would rather die than have, severe loss of motor function. And of course, people who do have higher levels of disability, if you're disabled, that's sort of an indicator of earlier mortality, right? So, the quality of life is not so good. So again, this is all obvious stuff, but showing the importance of, how we can, better educate our patients and educate our public about, recognizing the symptoms early and getting to care earlier. Again, just some of the psychological impact, depression, the physical impact, not being able to speak or communicate. You can see hemiparesis, paralysis on one side of the body. About half of the people with stroke or require some kind of assistance just to walk. And again, this is devastating for people, and certainly the reason that we should, be emphasizing the importance of quick care. And we make a difference, right? EMS makes a difference. Certainly, the EMS use is strongly associated with decreased time to initiate a physical exam. Obviously, you're getting them to the hospital quicker, so they can get to, definitive care a lot quicker. The other thing about, using 911 versus, driving a car is certainly if something goes wrong en route, you can certainly take care of it. And then you're certainly more aware as to which hospital is most appropriate. So again, the reason that people should be using EMS for stroke symptoms. And, EMS educational programs, again, how you educate your patients, how you educate the public, certainly causes increase in public knowledge of stroke signs and symptoms. I think that people are well aware that if they're having chest pain, they may be having a heart attack. So I think it's our job to make people know that if they're having, some of these symptoms that we've talked about, that they may be having stroke. So again, this is sort of, some of this stuff was already mentioned, but I think these are the key components of an EMS assessment, and then the patient history. Again, it's very important to note the onset of symptoms, right? When did you last see the patient normal? When did this all start? You can get that information from family, bystanders, whomever. Again, if you have to transport someone with the patient, if a witness to say, yeah, I saw him, normal 2 hours ago, and you may or may not need next of kin for either for information or consent, right? If these are people that are going to go on to get TPA for stroke or get definitive care for stroke, they may need someone to consent for them. So again, transporting people, witnesses, next of kin, whatever, with them is sometimes helpful. You want to know about recent events in their history, right? Have they had a stroke before? Is this a second or a third event, or have they had a stroke recently? If they've had a history of MI, again, vessel disease is vessel disease. If certainly doesn't, if you have plaques in one vessel, you can certainly have plaques in another vessel. Trauma, you want to know about trauma because if there's any risk of bleeding, or certainly, if they do have a hemorrhagic stroke or bleeding, is it because of trauma? Surgery, recent surgeries, again, if they have a propensity to bleed or they're going to bleed out of a recent surgery site, or if they have any history of bleeding, then you may not be able to give them a clot busting medication, if they have that in their history. I'm just going to check the chat box here. It looks like I don't know if we have. Okay. Comorbid diseases, again, you want to know their past medical history. Do they have hypertension? This becomes important when you start getting, blood pressure readings, certainly, and to know if somebody has a hemorrhagic event. And if they have diabetes, again, I talked about how diabetes affects blood vessels. Use of medications, very important to know, obviously, if they're on anticoagulants, if they're on aspirin, Coumadin, Plavix, Xarelto, any of the novel agents. So, especially if you determine they have a hemorrhagic stroke, you want to reverse the effects of the anticoagulants. So it's very important to know if they are, in fact, on anticoagulants. Insulin, again, if they're on insulin, that sort of, tells you that they are diabetic if they can't, right? So if you notice that on their medication list is insulin, then you know that diabetes is playing into it. And same with antihypertensive. If you see their medication list or their goodie bag of medications, you see some antihypertensives in there, you know that is part of their history. With your assessment, again, ABCs or CABs, however you want to list it. Certainly the primary things that we have always done, we're still going to do. And then you want to do a focused exam, certainly a focused neuro exam on someone with signs and symptoms of stroke. Just some vocabulary that you may hear when you're talking about stroke, or certainly can use when you're describing stroke. The first is aphasia, or inability to communicate. So receptive aphasia means that they can receive, they can't receive, so they can't understand. They have the ability to speak, but they can't receive information. So that's receptive aphasia. They're not able to receive. Expressive is the other way around. They can understand what you're saying, but they can't speak. So again, this is expressive. They can't express themselves. And then global is they can't do either one. So can't receive or express. And you can see that those are types of aphasia. Hemiparesis is weakness on one side of the body. So you can say somebody has hemiparesis or they're hemiparetic. Hemiplegia, on the other hand, is paralysis of one side of the body. So if somebody's hemiplegic, they're paralyzed on the right side, left side, whatever, one side of the body. So again, this is just a way to describe some of the findings. Ataxia just means an alteration in coordinated motions. People who can't walk, fall to one side. Their gait is ataxic. You may describe their gait as ataxic. And then paresthesia is just a sensation of numbness or tingling. And again, this is some terms that you may use or hear when certainly describing stroke. And then we talked about those stroke assessment tools, right? We talked about and certainly the FAST exam, which is the Cincinnati Stroke Scale. So this is the FAST tool, right? F-A-S-T. F is for face, A is for arm, S is for speech, and then T is for time. So this is the FAST mnemonic or fast tool for stroke. And this is essentially doing the Cincinnati Prehospital Stroke Scale, which is what we talked about. So F, again, facial droop. A is for arm droop or arm drift, I should say. And then speech is for difficulties with speech. And again, this represents the Cincinnati Stroke Scale. The Los Angeles Stroke Scale or the Los Angeles Motor Scale is a bit more, the Los Angeles Motor Scale on the right. You should be familiar with that if you're practicing in Rhode Island. This is the, you get points for facial, arm, and then grip strength. So again, this gives you a score and a scale. So if the score is greater than 4, this is when we're talking about going directly to a comprehensive center. So again, to do this, F is for face. Face asks the patient to smile or show you their teeth. I know I've told this story before, and I'm sorry if you've heard it before, but I was dealing with a young person who was having a stroke, or I thought was having a stroke, and I asked him to smile, and he started to cry. And he said, "How can I smile when I'm having a stroke?" So since that time, I have never again asked a patient to smile, but rather I say, "Show me your teeth," so that it's so again, it's the same motion, but certainly doesn't carry any other meaning. And then when they do show you their teeth, you can notice either facial symmetry or either a left or a right-sided facial droop, and that is how that's how you get the F for face. Arms is called pronate or drift. You certainly have their patients in the pronated, so palms down, their arms are pronated. You have them hold their arms out for 10 seconds. And you have them close their eyes, because if they do have drift and their eyes are open, they may utilize other muscles to kind of keep their arm from drifting. So have them close their eyes so they can't see what's happening. And then if the test is abnormal, if one of the arms drifts compared to the other, and that's pronate or drift. S is for speech. You ask the patient to repeat a simple sentence, no ifs, ands, or buts, or the sky is blue, or something simple that they can repeat. And you note if they're slurring words, or if they use incorrect words, or they just, can't speak at all. So certainly that's how you evaluate their speech. And then again, time, time is brain. We've said it a million times, and certainly when was the last time they were normal, and then, getting them to the appropriate stroke center. So that's the fast mnemonic or fast exam. And so they looked at this this is 2017. They looked at the FAST exam or the FAST score, and they said, well, how good is this? And they found that the FAST score, with using the FAST score alone or the Cincinnati score alone, you're missing about 14% of strokes. So the FAST exam, they determined, really wasn't that good. So because you're missing about 14%. Again, you're missing about 14% of strokes. So what they did is they added the two other factors, balance and eyes, so that it's now B fast, right? And they found that now you're only missing about 4% of strokes, and that translates into meaning that you are correctly identifying more than 95% of strokes. So this is a pretty good score. This is a pretty good scale. It adds balance and eyes to the FAST exam. Balance meaning, are you able to walk? Are you, off balance? Are you just not able to walk? Are you tipping to one side? Again, this is, for measures coordination and certainly the cerebellum. Eyes, do you have any problems with vision in one eye, both eyes, etc.? So again, this now B FAST exam identifies greater than 95% of strokes. So this is a good score to use. So out of hospital, what are we going to do? Again, I talked about this a little bit, but I kind of want to go over each of these points, because there are things we can do, because you say, yeah, that's great, but what can I do, en route to the hospital, or what can I do for the patient that's going to make a difference? And there are things that you can do out of hospital. The first thing is transport position. So our goal really with stroke is to restore blood flow to the brain, right? We talked about that. I mean, that's really what we want to do, is get blood flow back to the brain. Traditionally, we've talked about people with, neurologic conditions that we elevate the head of the bed at about 30 degrees. Not so with stroke. This is a time when, if there are no, there's no airway compromise, there's no worry about increased intracranial pressure. This is when you can, put the patient at 0 degrees, lying completely supine, because gravity is going to help you in this case, right? Gravity is going to help you increase blood flow to the brain because the patient is lying flat and blood doesn't have to travel uphill. So again, if there's no concern for increased intracranial pressure or airway, lie the patient flat. Oxygen, of course, decreased O2 sats can worsen cerebral ischemia. The whole idea is to get oxygen-rich blood to the brain, so we got to get oxygen to the brain. Last month we talked about trauma, and again, the magic number was 90%, right? You want to have the pulse ox certainly above 90%, and then in this case above 94%. Hyperbaric oxygen certainly shows no benefit. Hyperoxia, meaning, high flow oxygen, lots of oxygen, can actually be harmful. So really, all we're asking you to do is just to monitor the O2 sat and keep the sats above, certainly above 90, 94%. So again, treat hypoxia with supplemental oxygen. IV access, stroke is a time-dependent emergency. If you're going to spend a lot of time in the field trying to get an IV, you're making multiple sticks, trying multiple times, don't do it, right? It's a time delay. If you can, if you can get an IV en route, that's great. If you can't, not a big deal. We may need it for resuscitative medications. But again, don't spend time, trying to get an IV because again, that's a time delay, certainly on scene. IV administration, should you give fluids? There's been talk about, giving hypertonic saline or glucose-containing solutions. Certainly, if the patient is dehydrated or poorly perfusing, give IV fluid boluses, just like you would with anybody else. And again, if they look like they need fluid, you can give fluid. But if they're hemodynamically stable, just lock the IV or just, run it at KVO or something. They certainly don't need a lot of fluids. But again, the IV is going to be helpful if you need to give medications. ECG monitoring, of course, is important. Patients that are at risk for adverse cardiac outcomes secondary to the release of catecholamines. You can get an increase in sympathetic tone, may cause a heart strain or an MI. About 10% of patients who are having a stroke are having an MI at the same time. So remember that. So because of either the catecholamines or the sympathetic tone, about 10% of patients are going to have an MI concomitant with their stroke. The other thing to remember, as we talked about, is stroke can be caused by or certainly increased in patients with AFib or a prior MI, particularly an anterior wall MI. So again, you may put somebody on the monitor and see that they have AFib and then know, that they probably had an embolic event from AFib. So again, the cardiac monitor is important. Certainly at least 3-lead ECG monitoring is recommended, 12 lead if you can. Again, avoiding any time delays, but certainly ECG monitoring. Blood glucose monitoring, I talked about this. I think we understand this, but, certainly hypoglycemia can mimic the signs of a stroke. You want to make sure the patient's not just simply hypoglycemic. So you want to get a capillary blood glucose as soon as you can. And also hypoglycemia can lead to brain injury. So you're going to, treat hypoglycemia just like you would with any other patient. You're going to give either D50 or oral if they're awake. And then the other problem is that hyperglycemia is an independent risk factor for increased morbidity and mortality following stroke. So we're not giving glucose to people who don't otherwise need it. Hyperglycemia is, as you see here, worsens cerebral edema, enhances hemorrhagic transformation of stroke. So if they're having a ischemic stroke, it can start to bleed and certainly exacerbates the injury. Early insulin therapy, of course, in the ER, we know that this is not a pre-hospital event, but certainly we're going to keep, glucose monitored very closely and make sure that they're not hyperglycemic, but certainly you can identify it in the field and then treat it if it's low. Aspirin, aspirin is important. Platelets are responsible for that clot formation that we talked about that causes this whole cascade to start. Aspirin is an antiplatelet agent and certainly something easily available and easy to give. And it's been shown that early aspirin therapy, within the first 48 hours reduces the immediate risk of further stroke or death in the hospital setting. So aspirin is really, a good thing for patients with stroke. The issue is we do not want you to give aspirin, certainly in the field, and we don't even give aspirin in the ER until we've done like a formal swallow study. Now, remember, people who are having stroke, they have different parts of the brain involved. One of the things that may be involved is their ability to swallow and swallow correctly. So to avoid any aspiration, we don't give anything PO, certainly until we do that swallow study. And so that precludes you from doing it in the field. So again, although it's important, don't administer aspirin in the field. Blood pressure management, I mentioned this is controversial, and certainly, there's not a good feeling for what to do there, but we know that cerebral blood flow is maintained at a constant level by something called autoregulation. We know that arterioles dilate and decrease resistance when blood pressure is low, and they constrict to increase resistance when blood pressure is elevated. So the arterioles are managing that automatically. And how does that happen? Well, it responds to changes in the PCO2 levels when blood flow is then increased to regions of demand when the brain is actively metabolizing. So again, we're auto-regulating all the time. What happens though is that autoregulation mechanism is disrupted when we have ischemia. So that's no longer functioning. So cerebral perfusion depends almost entirely on systemic arterial blood pressure. So to get blood to the brain, we need a little bit of extra kick, if you will. We need some increased blood pressure. And so the initial hypertension associated with a stroke may actually be protective. It may actually be helping blood get to the brain and get to that area of the penumbra that we're trying to preserve. So again, high blood pressures in the beginning may be okay or protective. Hypertension is common initially after an acute ischemic stroke. You may see people are quite hypertensive, but even after time, after about 90 minutes, it kind of levels off even if you don't intervene. And studies have shown that if you do lower the blood pressure, lower than certainly is safe, it can actually worsen the outcome. So again, we're going to kind of leave blood pressure alone for a bit. For an ischemic stroke, a systolic of 140 or even 180 up to 180 appears optimal. So again, you're going to permit these higher blood pressures initially to get blood, to the areas that are blocked or certainly the penumbra. And we're really not even going to intervene until, systolic gets maybe above 220. So when it's real high, we're going to intervene. So again, not much to do with blood pressure, and certainly not in the field. I would just kind of leave it be. So, again, if it does become an issue in the ER, it's usually a drip that's used to manage the blood pressure control. So again, no intervention in the field is really needed. And certainly in Rhode Island. I mean, if if you end up working in a place where you have hour-long transports, we can talk about that. But certainly where we are, we don't need to intervene at all. This is the protocols for stroke, and again, we've sort of touched on all of these things. All of these things in the protocol. You see the score there is the LAM score, and that's spelled out for you, so you don't have to memorize it or remember it. And again, LAM score greater than 4. They want you to go to a comprehensive stroke scanner. Otherwise, you can go to the nearest. I'll just say the nearest hospital, because whether you're going to the primary stroke center or an acute stroke ready hospital, both are capable of handling stroke. So we're lucky in Rhode Island, you can go to any hospital you want. There is also a protocol for TPA for obviously paramedic level only. It's quite involved. I don't know if anybody's ever has done it in Rhode Island. I'm not sure. If you're on rounds, if you're on the call tonight, you can certainly let me know if you have done it or you know somebody who's done it. But again, that protocol is there. So again, just recommendations for stroke systems. This comes from the Stroke Association and the recommendations made for EMS. Number one is, rapid access to EMS for patients with stroke symptoms and dispatch of EMS. Of course, that starts with 911. Public education, as I talked about, educating your patients, your public about the signs and symptoms of stroke so that they recognize them early and get to care early. And then, even primary care providers knowing, what to tell patients and when to call 911, et cetera. Knowledgeable dispatchers, certainly, when a dispatcher hears certain key words about a patient or, something happening, that they identify this as a potential stroke patient, and know that they have, limited time to get somebody there and get activated. Also know the point of entry plans, again, which hospitals are appropriate to go to, et cetera. And they really need to, priority dispatch these just as you would, like I said, like an ST elevation MI or trauma. Certainly we have taught people to recognize that. We have to teach them to recognize stroke as well. Direct involvement of ER docs and stroke experts for education protocols, et cetera. Well, I think that's why you're here tonight, is to learn about stroke and what you can do for stroke, et cetera. And then we talked about the importance of going to the nearest stroke center and certainly pre-notifying that center so that you can, so that they can best be prepared for your arrival and with everybody and everything in place as need be. And then documentation, certainly document your screening scores, et cetera, and why you chose to go to where you did, and et cetera, et cetera. And of course, that becomes very important for, the further care of patients. So the importance of EMS, again, you can see anywhere from 1/3 to 2/3 of patients will access EMS for their care. A majority present within 3 hours, about 1/3 within 2 hours. I guess the point of all this is that people who utilize EMS comprise the majority of patients presenting within the 3-hour window, which is necessary for TPA. So again, EMS is important. We all know that, but EMS is important to get patients to the hospital quicker, and certainly to the right hospital where they can get the correct stroke care. All right, so in summary here, again, stroke is a leading cause of disability. We certainly know that can have long-term impacts if we don't do something. Less than half of 911 calls for stroke are made within the first hour of symptom onset. So again, we want to make sure that we get the message out that, stroke symptoms are important and need to be treated certainly quickly. I just want to talk a little bit about what happens in the ER because, it's important to see the continuity of care, what happens there. Certainly when you arrive at the hospital with a patient that you suspect is having a stroke, that starts our clock, so to speak, now the in-hospital clock. And with the goal of a door to needle time, meaning, you're giving TPA within an hour, within 60 minutes. And this is just sort of a time frame of what is kind of expected. Certainly the patient should be seen, by an MD or provider, in less than 10 minutes. The stroke team is notified, the patient goes to CAT scan, you get the results of the CAT scan in the labs. And then again, in under an hour, you should be talking about whether or not the patient is going to get TPA. The good thing about pre-notification is this whole thing can happen simultaneously, right? So all of this beginning stuff, some of you who have come to Fatima, perhaps where I work, if you've pre-notified us, you come through the door, we go directly to CT, right? We bypass most of this stuff happening. The stroke team has already been called. The doctor's already there, probably seeing the patient in CT on the CT table. So you've cut into this time already. So again, that's the importance of pre-notification and the assemblance of the stroke team and getting everything in place, and then working on right down to registration and registering the patient quickly so they can get a CT. And we go right over there. Neuroimaging, they go, I mentioned obviously that they go right to CT. Well, why is that so important? Well, obviously you want to immediately differentiate, is this something hemorrhagic or is this ischemic? If it's hemorrhagic, then, everything kind of stops, right? You're certainly not going to give clot busters to somebody with a hemorrhage. So you need to know the difference right away. So somebody with a hemorrhagic stroke, and again, these are certainly less percentage of the patients, but if that's found on CT scan, then the rest of the sort of the cascade doesn't fall into place. Certainly different mechanisms do, but if it remains that it's ischemic, then certainly we move on, on the clock. You occasionally can see an acute stroke on CAT scan. This is a CAT scan of the brain. Up here, you see it kind of looks a little less dense, and certainly that's an area of an acute stroke. But again, the reason for the immediate CT scan is not to identify the stroke, but just to identify whether or not it's a hemorrhagic stroke. And then the other thing we're doing now is to determine whether or not this is what we call a large vessel occlusion stroke, right? An LVO. And that's mentioned in the protocols as, a LAM score greater than 4, is suspicious of an LVO, a large vessel occlusion. So that's why they go to the comprehensive stroke center. So if you come to a primary stroke center or an acute stroke ready hospital and we do a CT scan, what happens is they do a CT of the brain to look for bleeding or not bleeding. And then after that's done, then, if it's a hemorrhagic stroke, then everything stops. If not, if it's ischemic, then what they do is they inject dye into an IV, and then they look at the large vessels in the neck and the head. And if there is a large vessel occlusion or an LVO, then that is indication for a thrombectomy, and that's a patient who needs to go to a comprehensive stroke center. So again, this is all done in a timely fashion because we get the CT right away, this stuff right away. And again, our goal is your goal, with the 60 minutes in the hospital or less than an hour in the hospital, again, is to, preserve the penumbra. You can see there the stroke patient loses 32,000 brain cells every second. So we want to reperfuse that area and keep it from extending. So EMS call to action: know your pre-hospital stroke scales and protocols, and I'm sure that you do. Again, you look at the stroke protocol, the scale is right on there, the LAM score is right on there. Know the capabilities of your hospitals, and certainly ask for feedback. If you're not getting feedback on strokes in a sort of a formal way, then certainly ask for feedback. And again, if you're in Rhode Island, you're pretty lucky. You can go to any hospital and be able to get thrombolytics. And again, spread the awareness, educate your community, educate folks about the signs and symptoms of stroke. Make it as important as chest pain for MI. Make it important to people that they, recognize these things, and then activate EMS for a call to action. Anybody have any questions? And again, you can certainly unmute yourself, ask questions, or share them in chat. Either way you want to do it. But does anybody have any questions about stroke?
Doug, I have a quick question. The LVO, is it greater than 4 or greater than equal to 4?
The protocol says greater than or equal to 4. Yeah, so it's again, the scoring. Let me see if I can just bring that up quickly. Yeah, so here's the protocol. So yes, greater than, to be correct, you are correct, greater than or equal to 4. So again, when you score on the LAM score, if the score is 4 or above, then you're going to a comprehensive stroke center.
Thank you.
You're welcome. Good question. Anyone else? Let's see, there's a chat there, somebody in the chat. Any other questions on stroke care, anything else? And again, as always, if you have ideas for rounds or requests for rounds, if you have any special topics, you know, certainly let me know, and we can, you know, try and get them in. But thanks everyone for attending. Thanks. You know, I think Eileen will email you your certificates, and if there are no other questions, Eileen, I think we can stop recording certainly.